It would help if you press the live button when you're gonna go live. We were talking for 6 minutes straight. Hello, everybody. So we are here. You were here before we were, technically, because I don't even know what I was thinking. I just knew I hit the live button and was talking her head off and giving us all the business about what she does. So peace, everyone. Thank you for joining. So, welcome to Information with Deidre, the Public Health Career Spotlight. We are talking to a medical director. Thank you, my precious Stephanie. Thank you, loud and clear. Because it was, if you don't press live by a certain time, you're not going live. It'll just cut it off. So everybody would have been sitting there. We would have done a whole show and not known anything. So give thanks for the heads up and the tap on the show that I got. Like, you're not live. So welcome, Dr. Walters. Welcome. So tell us a little bit about yourself, what you do, and your profession. Start all over.
So currently I hold the role of medical director in the hospital system that I work, and it's medical director of our ambulatory services. So essentially my role, and I'm under our chief medical officer's department, is kind of twofold. One is to ensure consistency and physician engagement. So to ensure that our physicians have the things that they need to be happy with what they do, and that we have consistency among clinics. We have primary care clinics, we have specialty clinics, we have clinics in the community, and we have clinics that are attached to the university program. So there's a lot of different moving parts. Everyone does things differently, but we want to maintain consistency. And part of that is ensuring quality of care, which is another point of control or another department that the CMO is responsible for. So I help assist in making sure that we do have consistency and quality of care among our clinics in the outpatient arena.
Okay, thank you for sharing that. I just want to take a second and go over to the chat. Thank you, everyone, for joining us. Peace and greetings and good evening, Sister Kashia. You ready? I'm glad y'all were. I thought I was. Peace, Sovereign Eve. Peace, Precious. Peace, Chief Yuya. Thank you for being in the space. Peace, Maxine. And thank you for joining us. And as always, so we are very interactive with the chat. So if there are questions, please feel free to ask, and the questions will be answered to the best of our abilities. So normally at this point I would ask, like what public health field does it cover? But being that you're in a hospital, it's probably like the gambit, right? Like you probably, because usually like when we talk about like what public health field like your profession covers, it's relating to like the different areas, right? There's health law, there's social and behavioral sciences, community health, and da. So like, I'm sure it's very broad, but can you give us an idea of the different public health fields you cover? Because there's a specialization being a physician with an MPH.
And I will say, at least through my career after I finished med school, because I did my MPH prior to med school, and then I went on to work. And so I will say in my career so far, after finishing med school and my training, I have actually done quite a bit in the gambit in terms of my public health training. So we definitely in the hospital, epidemiology is a big part of it. We have to track harm events. We have to track infection outbreaks that happen in the hospital or coming in overall. We work very closely with our Department of Health when it comes to those types of things, especially communicable diseases. So for a while, I was the hospital's epidemiologist, and so kind of chairing the infection prevention department and working with them in that regard. Now that I'm switched to kind of the ambulatory space or the outpatient clinic space, I do a little bit more of population health and looking at social determinants, because those are part of the things that help drive quality and patient satisfaction. Right. So whereas, medical care is individualized, I'm looking at one person and one person only. Then as in the administrative role, I have to look at population health. How do we get patients to be compliant? How do we get patients to get the care that they need? How do we ensure that the quality is at a certain level? And so that looks at the whole overall with social determinants and kind of population space.
Awesome. Normally I would be like, oh, what, different locations, like what are some of the physical locations like your job has brought you to? Because public health can kind of take you places, but obviously it's the hospital. So what I really want to know, because you talked about being in ambulatory care or the outpatient clinic setting, what has the experience been like over these past 18 months with COVID?
Oh my gosh. So this is very important, and I think it's a big part of kind of public health overall too, because when COVID came in, there were a couple of things that needed to be started. One is having kind of an incident command, having someone that overarching looks at the big picture, looks at what is needed for the community as well as the hospital as a whole. And so that was one of the things that was instituted at the beginning, just having that command center that looks at guidelines, that puts them out, that looks at what the CDC says versus what we need in our community versus what we need in our hospital system, which is again a small community because we have thousands of employees. So we have to look at our employees. One of the things that I was very instrumental or worked with was actually initiating our employee testing. How do our employees get tested? How do we work out with HR their time off? How do we get the data to the Tennessee Department of Health? How do we look at infection outbreaks? So it came into a epidemiology part of that as well. When you have one person and they work in the laundry and then another person in the laundry, now do we need to look and have everyone tested in the laundry because we have a mini outbreak of COVID in that area? So at the beginning of the pandemic, that was something that was very instrumental, or we worked a lot kind of overall. And then again, setting protocols for the hospitals. How do we continue to have care for all of our patients when they can't come in, or when this clinic is close to them but it's closed and this other clinic is further but it's open? Like, how do we maintain our health when we look at our patients and they're unable to get their medications, they're unable to get transportation now because the buses say, oh, well, you can only have 5 people in the bus. So transportation now becomes an issue. Poverty, if you live in an area that you don't have a car, here in this area is not very good to get around. So one of the things that was instrumental that we were able to do was to initiate our telemedicine options. And we were able to do that and work with our pharmacies. Our pharmacies developed a home delivery program for patients to be able to still get their medications. So kind of coordinating all of that in the pandemic was very, very important. Again, to finish quality of care and to ensure that patients get what they need despite their problems.
Okay.
My dog decided she wanted to come and say hi.
Hi. Hello.
I don't know why she did that.
I'm gonna be on camera too. What's her name?
Mika.
Hi, Mika. Mika.
Yep.
Mika. Over here, Mika.
It's thundering a little bit, and she's afraid of the thunder, so she got a little closer to me.
The storms have been like ravaging the East Coast, I guess. Well, no, you're kind of central, right?
I'm in the South now.
You're in
I'm in Tennessee.
Yeah, but it's kind of over like that.
Yes. Southeast, yes.
I'm like, it's like down and then like right there.
Yeah.
So I'm glad you like brought that up because I'm in the Northeast, like up in the New York area, and in a place like New York City where you do have mass transit, it's both pre-COVID, getting to, your clinician or physician is not necessarily difficult, but it also depends on where you are. If you're not near a hub or you're in a place where is like a train or subway does it, when places that are further out from like the center, like Manhattan, then it's difficult. And so people do have to think about, like, transportation. Am I able to get to where I need to in order to, access care? That's
Yeah.
critical. So, like, we had a whole True Health Live on television. So, I don't know what happened. We had a whole True Health Live on telemedicine. So make sure you check that out on deidreselly.com. But tell us a little bit about like your path. Like, how did you get there? So part of what you guys didn't hear, because we were talking to no one, Dr. Walters and I are actually classmates. So we attended university together for our master's degree. So this is our connection. That's how we know one another. And, so this is a good example of like the different ways that you can go. So we were both in getting our MPHs at the same time. And afterwards, Dr. Walters went to med school and I went straight into, I don't even know, work. So, and then like, then you see like the evolution as we, grow within our careers. And so here we are. I'm in advocacy and she's a whole doctor and the director of a whole part of a hospital. Yay. So tell us a little bit about your path, like, and you can start from the beginning, like what was in your head, like,
Yeah.
we'll talk about like, well, this is what I wanted to do and this is where I ended up. So, give us a little bit about that.
So I will first say that in my radar was not something called a master's of public health. I don't even think I knew what it was. So when I started off in undergrad, my plan was to go to medical school. I was going to be a doctor. I wanted to be a pediatrician, a NICU doctor type thing. And after undergrad, I was still relatively young. I think I was 2021 when I finished undergrad, and I wasn't sure. I know I said I wanted to be a doctor, but I never actually worked in a healthcare setting. So I decided I was going to take a year off and go back home. I'm from the Caribbean, so I grew up there, and go back home and work at our hospital. And what I did is I work at various areas in the hospital. So I did some administrative stuff. I worked in the lab for a little while, and they were very accommodating. I worked in the pharmacy just to see like a lot of the multidisciplinary parts of healthcare. And so while I was there, I'd interacted with someone who had a master's of public health. And I'm like, what is that? Because, I know about like masters of business, masters of like finance, all that type of stuff, but I'd never really heard or thought about public health at all as a part. And so I started to delve into it. And I said, you know what? I think I really want to do this before med school because, again, for me, medical science is kind of individualized health and public health is kind of on a grander scheme. So I figured, okay, this is going to help me kind of understand and kind of look at things a different way when I get into med school.
Yeah.
Still had no clue whether I would do something with it, whether I would like it or not. I'm just a nerd. So I was like, hey, I'm going to go to school and do this master's program. So that was kind of my impetus to apply and get in. And then my concentration was in maternal and child health. And that was simply because I was still saying, I'm going to be a pediatrician. So the maternal and child health will kind of work in whatever field that I want to do. What I didn't recognize when I started my master's program was how much it influenced how I do my medical science. And so I did the master's program, learned about epidemiology, statistics, learned about social determinants of health, and it was very interesting to me. It was something that I think it kind of changed my trajectory overall, because even in my medical science, I always look at social determinants of health, health equity. Those are big things that are important to me. And it helped make the decision on where I went to practice and how I practice overall. So after that MPH, I went to med school. After med school, I did my my specialty training. And one of the things I always thought is I would lose everything that I had learned about in my MPH because I never actually went and did a job in public health. I went straight into medical science, and then medical science, again, individualized care. If the patients don't care about social determinants, the patient don't care about health law, they care about themselves right then and there. And so it sometimes was a struggle for me.
Mm-hmm.
But what I try to do is use my volunteering efforts and my projects that I did during my training to do things in public health. So worked on a nutrition program with kids in a disenfranchised neighborhood here, like developing programs like that. So I still kind of had my finger on somewhat of a pulse of what kind of public health was. But I've always had an interest in like population health and social determinants and inequity and things like that. So it was really important when I got this role. It turned out to be kind of my perfect role that I was able and I had the ability. I've been in the system for a long time, and I know a lot of the people who are in charge, and so they give me a little bit of freedom to kind of direct things the way that I want to, kind of in this role. And one of those things is preventative care and using statistics and epidemiology to drive behaviors in our employees and our patients abroad.
Yeah. And I think that speaks to like one of the main tenets, like, right, of public health, which is preventing disease, like promoting health and preventing disease. And for the life of me, I can't remember the other one, which is not good like right now. But specifically what you're talking about is preventing disease. And similar thing. It was just like, well, because I also wanted to do the doctor path, but I figured that was not going to happen in undergrad. And I was like, just let it, let it. And I was like, but I still want to help people, and I want to do public health. And I didn't know anything about it because initially it was going to be like an MHA, which is a Master's of Health Administration, because that's everything was. It was about hospitals and insurance, health insurance, and managed care and HMOs. And then when I learned about public health, I was like, well, why didn't I tell you about this sooner? It can help like so many people.
Yep.
So it's just like you said, it's like I wanted to be able to do something that would help on a grander scale and not like individualized, things. And honestly, I don't know how much help I could have been like working for an insurance company. It's not really about the patient. So, when it comes to like public health, you really have to be, of the mindset that you are, of service to other people. So that was I think what really drew me in and drew me to it. I was like, I wanted to be in service of patients and, obstetrics and be, help, bring babies into the world. But I'm probably going to be better at it.
And I think it definitely made me a better physician because I look at things through both lenses. And so, I see like, I work with the university, so I help train residents that come up in the program. And sometimes you can see the difference. You can see that they don't step back and look at that worldview on how these things, how to prevent disease, how, patients are coming into the hospital. Well, why are they coming back into the hospital? You're just frustrated that they're coming back, but there is a bigger societal or a bigger reason why they continue to come back. How do you step back and look at this and say, hey, well, you know what? This is happening because of this. And we're using this to make change in behaviors and make change in processes and policies that will help kind of reduce it. And so that has, I find that now that I'm later in my medical stuff, that I actually am more towards the public health type stuff that I do in medicine. And so I think it wasn't my trajectory, but it worked for me because this is what I wanted to do.
Yeah, that's great. You know what, you mentioned something about like I guess like the fellows and residents, like, why are they still coming back? And it makes me think, like, especially when you're talking about service to underserved populations, right? In hospitals. And we know that a lot of the times what happens is people don't necessarily engage in preventative or proactive care. And then they end up at like, an urgent care center or the emergency room. So little bit about that and actually working with like those who are under you, who you are like mentoring to like help them understand like the reasons, because now we have where people understand, well, there's social determinants of health. Where you live determines like your access and the behaviors that might be perpetuated and continued and the mindset. So can you speak a little bit about that?
Yeah, and so again, the hospital that I work at is, or what you call our county hospital. So we do see a larger percentage of, disenfranchised, underinsured, uninsured patients, a lot more patients with mental health issues. We even basically house most of our prisoners and inmates in the area. So we see a large disenfranchised population, and you hear it all the time. Well, if you can afford some Jordans, you can afford to take your medications. But no one ever try to figure out that the person has a fourth grade reading level, and you just give them papers that has every medical term and it's not explaining to them what's going on. No one takes into consideration that yes, you're obese and you're diabetic and you need to eat right, but they live in an environment where there's no fresh fruits, and to go out of their house to go anywhere is dangerous. And so kind of working with residents is, I always tell them the biggest thing is to sit and talk to the patient, not just rush in and be like, hey, this is what's wrong, this is what we're doing, and leaving, which is we have a tendency to do as physicians. We have 20 patients to see, we have this time, administration says you have to see all of them by 11 o'clock. We have all these test things that needs to be done, and we don't actually listen to our patients. And so they continue to come back, and you never find out why. And, I've had so many patients that came in where things were late stage. And I'm like, why? Like, why did you wait this late? And they would say, well, I knew I couldn't pay. And I thought that if I came out and I couldn't pay, that I would get turned away. So I never really come. And so they don't even understand kind of even the health law and the policies that are set in that, no, if you're sick, you can be seen. We don't ask for money up front. I'm like, that's not how it works. And so just teaching them those parts of medicine, and I feel like public health is part of the human side of medicine. It's the ability to understand someone else's and be empathetic to someone else's problems, and understand that some of this is social policy, some of this is like social determinants of health, some of this is health equity that is built into the system, whether it was deliberate or not, it exists. And so to be able to work in programs, and like for instance, we had a grant, and I think this program was modeled after a program out of Jersey. And it is to try to reduce the frequent visits of uninsured patients. And it's basically an intense case management model. So you identify patients that are constantly using the emergency department as their primary care. Most of these patients are either have behavioral health problems, housing issues, access issues. And so it's easy to just run up to the ER when you could, because it's open 24/7. And so the program had been instituted. And again, this is a population health scale, intense case management. And what happens is you identify these patients, they're assigned a social worker who checks in on them, helps them get their medications for free. Giving them free medicines is cheaper than having them come into the ER all the time and have a bill that they don't pay. So they have collaboratives with the community. So they help find housing for them. They get them into their behavioral health visits, and they follow up. So they ensure that there's someone actually checking and making sure that this is happening, that these people are getting what they need. And they absolutely reduce hospitalizations and ED visits. I think the last time I checked, they saved the hospital millions of dollars, even though we're helping them by giving things away for free. Overall, you're saving the hospital and you're helping. And so that is a program that, it comes out of a different department, but I work really closely with the lady, and we always talk about collaborations, just because I have that public health interest about going out in the community and doing things that way. So I think when it comes to training, in medical school, you get to read a book on like social policy and those types of things, and you have one class where you discuss it. but it's not the focus of medical training. So I definitely think bringing that perspective to the residents help them to look and see things from a global perspective as well. And you know, it's actually helped with COVID, because one of the things that I somehow got into is I've done a lot of talks on COVID. I'm like, for my job, for my church, for where I grew up, on the news, all that type of stuff. And one of the things that's important, like when we were talking about vaccines, is understanding the difference between a public health strategy and an individual strategy. And understanding that, you know, the vaccine, you know, a lot of people talk about, well, you know, the CDC says this, and then they change their mind, and they say this, but it doesn't work for this person and that. And understanding that the CDC, in essence, don't really care about you one, they care about you plural. And so when they make their recommendations, they're having to take into consideration so much other things. They have to take into consideration economics. They have to take into consideration different policies when they make their recommendations. So like, for instance, Pfizer saying, hey, we think we want to get approval for a third shot, and the CDC saying, oh, we're not there yet. It's not that the CDC doesn't think that we need a third booster. It's that we have so many people who haven't even gotten the first one, and they still need to focus on the population so that we can get the full vaccination versus worrying about a third shot. So even that public health strategy to even explain things, whatever decision people make, but to help them understand, you know, when you get this recommendation from your doctor versus when you get a recommendation from the FDA or the CDC, it's on a different scale, and how you monitor and understand the differences between those.
Yeah. You said something like really profound. So when we have these bodies, these world bodies or national agencies that make health recommendations, and these are, you know, the bodies that we follow, that they follow evidence-based practices and whatnot. One thing that is really key, and this is why I'm doing this show, is like, information is key. Like, yes, you know, a lot of the times we lean on like, okay, well, this is what they said. The other part of that is understanding it for yourself. So not just like having the information and being like, all right, well, this is what it is. But this is where the individual part does come into play. Because like you said, their concern is the mass, the group. And that's the thing. There's an understanding that with that, there's going to be some losses and some outliers, right? So when something happens, it's like, you know, well, this happened and you didn't say that. This is why you have to know. And that's how you can make that informed decision, so that when you're deciding whether you're going to be vaccinated or not, you're coming from a well-educated space. And I'm very much the person who's like, you know, deciding to be vaccinated is a personal choice, because everybody has their reasons. Because the other part, what we don't necessarily talk about, is people are also opting to have alternative choices, you know? So it's like, what am I eating? What supplements am I taking? And which are, you know, plant-based things are the basis of a lot of drugs. They've been manipulated and, you know, torn apart and then infused with all kinds of like 50-letter words that we can't even pronounce.
That was made in the lab.
Going back to the beginning. And, you know, and these are things that work, right? You know, when we talk about things that help boost the immune system, this is what people are doing. So it's not that everybody's misinformed, because that's the new campaign, right? You know, that we're stopping misinformation and disinformation. People are, you know, number one, there are people who are informed about alternative forms, and that's what they're doing. But then there's also the information, the mixed messages that is coming from mass media. Well, we have nerve damage and heart disease, and these things are true, right? So then if this is, you have to be mindful of how you're presenting this information to people, because then they're going to go all over the place if they're not informed fully and have that understanding of, you know, how things are working, you know,
and,
people like,
and it's you know, it's information, but it's how you deliver the information as well. And this is a big thing. Like right now, where I'm from in the Caribbean, there is a big outbreak, and it's a serious outbreak. And it just kind of turned into vaccinated versus vaccinated, foreign born versus people from home, government versus everyone else. And I did a talk where I just kind of explained COVID overall. And I tell people, my job is to give information, is not to tell you what you do. You're grown. I'm like, we're all adults. And so, I have my preferences on vaccination versus not, or COVID versus not, or what COVID does and it doesn't do. Some of it is from, individual firsthand, like working in the hospital, seeing patients and all that type of stuff. But at the end of the day, I can only give you to help you decipher, just explain things out to you, and you can decide. And I think one of the biggest problems that I've noticed at home is that how the message is conveyed from government and other people, it is done in a way that it's off-putting, because then you get information in a way that you can receive it well, and then you get information in a way that you don't receive it well. You're naturally going to gravitate towards that information. So I think messages, making sure everyone understands every point of it, and then make that informed decision. I think, yes, we use misinformation. I don't know if we're asking people why, when we say someone feels this way, did we ask their reasoning why? And I definitely think pushing anything on an adult never works. You can't even push things on kids. They throw tantrums. So, and so if you can't even control your child sometimes to eat Brussels sprouts, how are you going to control an adult to tell them kind of what to do as well, and just kind of push it down their throat? It's not going to ever work.
Right. But for anyone who's watching this that has an aversion to Brussels sprouts but has never tasted them, they are amazing. Cruciferous vegetables, they're amazing. But anyway, so, I think having that information definitely helps to make better choices, right? So tell us, because I want to be respectful of time. So give us a day in the life. A quick day in the life. And if you think it's it's not boring, give us a day in the life of when you did work in the emergency room. But I always think outpatient clinics are very interesting, actually.
So I can give you a day in the life. I will tell you, I started this role maybe a couple months before COVID. So the day in my life now is almost COVID related all the time. But kind of usually, so on a usual day, I have a clinic schedule, except for that I do that 4 days a week. So usually on any day, I have patients from 8 to 3. And right now, I have one day that's different than the others. So on my Thursday, I do all telemedicine, and they're all COVID patients. So yeah, my Thursdays tend to be a little heavy because a lot of people are struggling after their COVID infection. So that's my Thursday. But on my other days, like I said, I start at 8. I tend to see patients. I see patients that just left the hospital. So transition of care is kind of another important thing to me, because that's one of the reasons why patients come back. There's not a good transition from when they left the hospital, ensuring that they understand what was going on and having someone check in and make sure that they're doing fine. So at any given day, I usually see patients either that left the hospital in the last week or two, or patients that were seen in the ER, has a chronic problem, does not have a primary care doctor, and wanting to ensure that they get plugged into the system with whatever the needs they have.
Yeah.
So those are usually. And our patients are colorful. I love my patients. I saw a patient today that had purple hair and purple pants and purple sunglasses, and I was like, "Oh, is purple your favorite color?" And she was like, "No." She changes for every breast cancer awareness month. She will be pink.
Oh, so what's purple? Because purple is my favorite.
I don't know what purple is for this month. I
normally, but what? Because I know the turquoise is the November for
I thought purple was pancreatic cancer, but I think that's later in the year. But I don't think it's this month. But that's what she does.
Oh, interesting.
So those are the patients I have. I mean, I had a patient the other day, and then this gets scary. He's like 6'4", has schizophrenia. He's pacing. You're in a room by himself, and he is mad. He is mad because he has a condition and he was on disability, and he got off his disability, had a felony, so he can't find housing, so he's homeless. He has got kicked out of disability, so he lost his insurance, and he's wanting us to get him back on disability. And I'm like, I can't do it. Disability is a legal thing. And I'm like, okay, I'll get you in with the case managers. He's in that program, that same program I talked about that has, patients that go to the ER all the time. He's in that program, and they're trying to help him, but there's a limit to what we can do in an institution when it comes to kind of the other parts of like health. And so he's very upset, and I'm wondering, oh my gosh, is he going to get up? And it's crazy because I log into the system, and the first thing that pops up is he's assaulted someone before at the work. And I'm like, okay, how do I temper? Okay, this can be, I'm in a small room with a big guy who's assaulted an employee before. Is this going to be one of those situations? So those are that's my everyday type thing and seeing patients. Yeah. And then in between that, part of my administrative roles, I tend to have like meetings all scattered in between. So I may have a meeting on, right now they're trying to modernize the lab system and the lab result system for like external labs that we use in some of the clinics. So then I become the physician expert or something to help with that. Or have a meeting where we're looking at our goals. Where are we in terms of our quality measures? Are we meeting them? How far behind? What do we need to do to change that? Have a meeting on things like that. So that's usually my typical day, seeing patients, colorful or not, and then having meetings, try to scatter them in between and be like, okay, well, my 1 o'clock patient doesn't come till almost 2. And most places have like a 10 to 15 minute late and you're done. Because we know of the issues, and this is again how policies change. We know our population, so we know a lot of them have transportation issues and all that type of stuff, parking issues, all those things. So our late time is usually 30 minutes, and most of the time they can get to be seen even in 40 minutes. So that tends to throw off the schedule almost every day. Like your last patient is 2, but you don't get out until 4 or 5 because everyone was late. And so it just kind of pushed the schedule a little later. But yeah, that is my typical day.
Yeah. I think it speaks to like whether they had transportation or not, like what's going on at home, what are the things that they're dealing with. Even the patient you talked about with the mental health issues, it's like what case management or even like advocacy is in place to like help some of those things, because like if they're not addressed, then it's affecting it's like a domino effect. Right. Yeah. Have you ever like in your career, like what residency fellowship at a teaching hospital? Because like as you're talking, I've been like binging on House. And there's a difference between like the teaching hospitals and the county hospitals. So I was curious as to if any of your time, like throughout this time, have you been at teaching hospitals?
Our county hospital actually is one of our teaching hospitals.
It is. Mm-hmm. It is a teaching, because because I think like when people hear county, they're like, but because it's not private, right? But the truth is, teaching hospitals are the best place to go. They gunshot wound, they got somebody to fix you. Stabbing, they got somebody to fix you.
And that's why our county hospital is so. Our residency program here, a lot of residency programs are like it and some aren't. So how our residency program is it doesn't have a university hospital. It has all the different hospitals. So you rotate, so you get an experience in the different systems. So we have a VA. So if you ever want to work into a VA and a military system, there's teaching there. And then we have 2 private hospital systems that, you get your teaching there. And then the county hospital, which again, is probably where you see most of the pathology, like because patients will know, hey, I have a lump on my breast, but I can't afford to go to the doctor, or I'm afraid of going to the doctor. And
Yeah.
so by the time you see them, they're a stage 4 cancer. So you see things a lot further along at the hospital that we're at. So it becomes a really good place. And our county hospital is actually the only level 1 trauma center in this area. So all the gunshots and all the motor vehicle accidents and all the stab wounds come here.
Mhm.
Um, and
Yeah.
so you get to see a lot of that. So we do, I trained here, and so I chose to work at this hospital because I taught the training here and the teaching here, and the type of patients you see, I think was the best place that I thought for teaching. And
Mhm.
so when I first got out, I was working in the hospital system itself, working on teaching teams like house. You have the resident, the chief
Yeah.
resident, and the attendant. So I did that for the first 5-6 years of my training. And then it's only in 2019 that I transitioned to the clinic space overall, and do in a little bit more of the administrative role.
Yeah. Okay. So and you said before, like, so you feel like you're using more of your MPH brain, and probably because of all of the, you know, I think that will come to play, right? Because we're right now, the keywords are health equity, right? Or health disparities. And so when you're seeing that actually in the clinical setting, it just like can't be ignored. And then because you have that background at MPH, you're like, oh, that's what this is, and this, that, right? So right, normally this is where I'd be like, what's one thing that, give us something that's, a pro and something that you can change about what's happening now where you are.
So and that's the good thing. And this is actually why I moved from the inpatient, the hospital setting, to the ambulatory setting, because I didn't think that I can make much change in the inpatient. It's kind of a faster speed, like get them in, get them out, can't really work on things, busy or doing 12-hour shifts. You just really couldn't do. And I've always wanted to try to affect changes in those areas, in the inequity, in the education, in the focusing on what programs and policies we can do to help combat some of the social determinants that we know exist in this community. And so it was one of the driving forces for me to do ambulatory, so that one, I have a less busy clinical day and the ability to do more kind of administrative stuff, and be kind of instrumental in the policies. So I think a pro is, I definitely am in an environment where the people who makes the decisions trust and honor my experience and my education, and they foster any changes in those types of things. And the people that I work with are big in health equity, but they're masters. They're non-clinical people. They're masters in masters in business, masters in health administration. So their focus of their study a lot is, how do we bring in the money? How do we make things kind of work? And so to have them be able to say, hey, yes, I support that global clinical population health social determinant part of it, is definitely a pro, kind of in the space that I'm in, and the respect that I get with my master's of public health degree. So that's definitely a pro. A con, I would say, is I am in a hospital system. So ultimately, the goal is the individual health. So if something needs to be dropped, it's going to be the policies that are working on health equity, or the policies that, or the programs that we would have to institute to say, go out in the community and get patients what they need for preventative care. Those are going to be the first things that go by the wayside when we have to drop something. And so it's to try to be that champion and keep it on the forefront of people's minds. But it's one part of it that I don't think I did a lot in my MPH program that I think is helpful, is how to show the economic advantage of doing these things. Because at the end of the day, the executives are all business people. And at the end of the day, it's the dollar amount. And they want to see a plus sign by the dollar and not a red or a negative. And so the question is, how do we translate these these preventative care things, these programs, these policies to try to improve health equity or social determinants, or taking those into consideration, how to equal that to a dollar amount that the executives can understand and see.
So I'm gonna go use these last couple of minutes. We have 2 questions in the chat. So Zach Latimer, brother Zach, peace. He asked, how do you separate? So this is about your story about the clinic, like what goes on in the clinic, the day in the life question. How do you separate situations like that with a guy who is schizophrenic from your personal life? Do things like that begin to wear on you?
They do. There's a lot, and that's just my personality, is why I couldn't be a psychiatrist. But there's a lot of it that happens. So say in that situation, he was very derogatory towards females in his speech. And so I'm in there and I'm thinking, why are you calling all the women around you out of their names? I'm like a female in there with you, and you're using all these words to talk about the case managers and the stuff that they're not helping you, and you're calling them all these things. And at the end of the day, I am a 5'4" woman in a room with a 200 and something pound, 6'4" man who is like at the edge of his seat, and he's schizophrenic. So, but I try, even though my brain is freaking out, like in the back of my mind on this can happen, it definitely, I try to always be objective. So, I know in these situations and a lot of these patients, they're not listened to. And I know that's a big thing with them. And so just understanding and endorsing what he's saying. He's saying, the legal system doesn't work for him, especially poor people. And we know that's true. So there's no reason that I'm going to say, no, I don't think that's the situation. I just say, yeah, that's true. But unfortunately, I can't change it today. And I was able, he was still upset, but he never got aggressive with me, because we did have a discussion where I honored his feelings. And, you see it every day. You see, the day you have a patient come in and you recognize that your coworkers didn't treat them appropriately because they didn't listen to them. Mm-hmm. Or I had a patient that had some yeast infection, I think under her breast area or it was some area. And she was an older lady, African-American older lady, which, like cleanliness for us is next to godliness. And one of the ER doctors was talking about her, about how she doesn't bathe. And so when she came to visit after the ER follow-up, she cried in the room because of how she said, Doc, I bathe twice a day. I'm always clean. And to hear this doctor talk about me in the emergency department and say, oh, you just need to bathe. And so those are the things that fuel me. At the end of the day, I live far from town. I have dogs. I don't talk on the phone much when I get home because I have to decompress. But it's definitely the thing that keeps me going. It's the thing that fuels me into saying, I have to do more. I have to do more for my patients, or even if they're not my patients, just hearing some of those stories or seeing that, knowing that, I have that training where I can be a beacon for them and be a voice in the system so that they're not lost. It just really fuels me overall.
Mm-hmm. Yeah. I'm so glad you shared that. Maxine, she also has a question, but she said that alone is training on emotional maturity, not taking things personally. Yeah.
It's hard. I'll be honest. Sometimes I'll be like, oh my gosh, I want to pop this person in this room. But
she didn't mean that, y'all.
But this is my brain and my body talk. Like what I think of, I do not represent in my face and how I speak to them. So I try my best to treat everyone the same and to talk to them the same way. And sometimes I get through to them and sometimes you can't. So it's just at the end of the day, it's that public health training. It's the masses. Yeah. You're not going to get everyone. They're going to be outliers. So I think that helps.
Yeah. So Maxine also asked, like, she's talking about the training, and she says, how is practicing at the training hospital compared to hospitals in the Caribbean? And you can share, like, if you want, like, where you're from, because I don't know if there might be a difference between the different countries in the Caribbean.
Yeah, so I grew up in the British Virgin Islands, and our healthcare, like we have one hospital, our healthcare system. So it's very different because, you know, again, and you were talking about, you know, the natural stuff and things like that, and a lot of people feel that because you're a doctor that all of that goes out the way. But I say I grew up in an environment where everything was treated with a bush. It was, you pick something, oh, you're hurting here, this is going on, go pick that bush outside and put it in some tea.
I don't know if Sovereign Eats is still on, but I willingly she heard that.
I know. So that's how I grew up, and like you said, and I tell people this all the time, every medicine came from a plant. I'm like, just about, they just figure out how to concentrate it, and like you said, add all the 50-word things to preserve it. But they're not, because it's not in the Journal of American Medical Association, mean that it doesn't exist and it doesn't work. Of course, what we know is there's not always money in that, so or research dollars or notoriety from studying a plant that your grandparents have used forever that we knew about. So there's not going to be a focus on that, and we can get into that and a whole lot of other stuff with the pharmaceutical industry. But the but the hospital system is very much still matriarchal at home. It's very much also patriarchal because, you know, the physicians tend to be male, and the patients go in, and whatever the doctor says goes, and no one questions, and they do what they have. The nurses still wear these uniforms that look like nuns. And
difference from like the British Virgin Islands versus other islands which are not necessarily, you know.
So the majority of them have similar things because they all had a British background. A lot of the Caribbean islands are from British rule, and then they became independent. So most of those still practice the same. Like, you know, the American territories like Puerto Rico and the U.S. Virgin Islands, they tend to be just like the American system. Mm-hmm. And then you have some of the others like the French islands and things like that, Haiti and Cuba, and that have kind of socialist. They tend to function a little differently overall, but it's pretty much a system that way. You know, where and then, you know, the primary doctor is your primary doctor. You don't just go to specialists. Here in the U.S., you know, you come in and you demand, I want to see a neurologist. And you're like, why? And they say, okay, because I want to see a neurologist. And the neurologist says, this was something your primary doctor could have managed. But, you know, you have that right in the U.S. And again, it's even different from Canada. I mean, I went to undergrad in Canada, and their healthcare system, again, is in a different way. In the UK is kind of like this. You see primary care first, and they're basically the gatekeepers that determine where you need to go so that specialists aren't inundated with visits and things like that. So, you know, I've been in 3 different systems where it's a little different every time. And I think overall, sometimes there is a little bit of a push at home. There's not a big push on preventative care. I feel like they don't really talk about it because they assume everyone know about it. Because, you know, culturally, you had all this stuff, you do all this stuff to help prevent disease. But what they don't recognize is as the generations go, that's getting lost. And so there's not that big push to work on preventative care. And so we're having young people in their 30s with bad diabetes and bad high blood pressure and obesity and, you know, smoke marijuana every day type thing. And so it's definitely something that I think we can develop as the community and the places develop, but they're not there yet.
Yeah. Thank you so much. Maxine says, yeah, just one quick judo chop. I guess when people are acting a funky. My sister says. So final question, because we are at the hour mark. Well, technically we started we started late. In our
Yeah.
world, we started on time. But what is some advice you would give to, given your experience, all of, the MD and the MPH, what is your advice that you would give to an MPH student or someone looking to go into the public health field or already in the public health field and just interested?
So I definitely, well, I will start with kind of a little bias. I think every MD student should do an MPH.
That's how.
I think it's a continuum that helps you understand kind of healthcare from a different perspective. I know, like you said, there are a lot of combined degrees, including you can do an MD and a law degree, MD and
Right.
an MPH, MD and a PhD. But I definitely think if you're wanting to do, especially primary care or be in the hospital setting, I think doing a master's in public health is definitely important. For the MPH people, I would say, in that field, make noise. Like we tend to forget, you're usually the ones that get ignored because people don't like to hear your message. You're usually the ones that are working in the background really hard, and it's like a thankless job, so no one knows you. The neurosurgeon that split the brain, everyone knows about them, and you get that notoriety from being a MD. But I think the true heroes and the true warriors in healthcare are the people with MPHs. And so, spread your wings, use it to infiltrate the healthcare system overall so that we can have better policies. They tend to kind of renegade you to or delegate you to like the health departments and nonprofits and places that do kind of preventative care. But I do think there are positions and there's a need within healthcare systems, within university systems, within private systems, to try to carve out those opportunities and kind of look. Like I said, I got a hospital epidemiologist position because I had an NPH. I would not have gotten that position otherwise. So doing that and working next to the individual providers to just make healthcare a lot better for patients.
Yeah. So thank you so much, Cyrilyn. I'm so glad you had the time to join us. Willingly, everyone in the chat got a lot of information and it was helpful to you. What I like to do is put the information down below. So if you have questions please use the comment section and you can, I'll put your LinkedIn information and people can
Okay.
ask questions via LinkedIn. Um,
Okay.
and we'll have like further conversation about like the alternative medicines, especially from an MD. I'm so glad you said that. So make sure you follow True Health Live and you'll be, and Sterling's finding this out right now. And so, live and Sterling will have much deeper conversation on the allopathic versus homeopathic medicine. We're going to have some of that conversation with our summer series on maternal health, but it's a larger conversation, especially with the conversation about vaccines and people being vaccinated versus and people being afraid and talk about herd immunity. So we definitely want to have these conversations and have all kind of well-rounded parts of the conversation. So give thanks, Sarah Lynn. Give thanks for everyone in the chat. Again, if you have any further questions, put them in the comments and I'll do read the comments and I'll try to answer them or reach back out to any of my guests so that you can get the answers that you need, because they got professions that I don't have and I can't answer those questions, but we'll make sure to get the answer.
Well, definitely. Thank you.
So, bye. Thank you so much. Greetings, questions. Thank you so much for presenting on a very balanced perspective on the MPH MD pad. Thank you so much. Peace, everyone.
Bye.